Welcome to this video on some of the most commonly used hormonal and non-hormonal medications that you might be prescribed by your GP or specialist for the management of pelvic pain. The list of potential medications used in pelvic pain is extensive and outside the scope of this video. So this session will largely be focused in on the medications that we can use to reduce or manage periods and bleeding, as this is often one of the main contributors to pelvic pain. We will then also briefly discuss some of the medications that act on our nervous system and are often used for more persistent or widespread pain and in other pain conditions. Ultimately, it's hoped that this presentation helps equip you with some more knowledge and empower you to understand what your options are to decide what's best for you both now and into the future. Just a quick disclaimer that obviously medications should not be your only management option with pelvic pain or endometriosis. There's no single medication that treats all type of pain. All medications have potential side effects and also contraindications, so other conditions or factors that may mean a medication is not suitable for you. So please check in with your GP or pharmacist to ensure that you're taking medications and supplements safely. Of course, there are always new medications and evidence emerging in this space, and there may be medications that your team use off-label, which means outside of the current guidelines, but they may be considered appropriate in some situations. Again, that's outside of the scope of today's presentation, but it's worth checking in with your healthcare team about your particular scenario. Ultimately, our aim is that you have as many tools in your toolbox for managing pain as possible. Consider how non-medication therapies like movement, nutrition, stress reduction, and sleep can also help reduce pain and improve hormonal symptoms. This presentation is for general education purposes and should not replace individualised healthcare advice. So, given the first part of this presentation is focused on managing bleeds and cyclical symptoms, if you haven't watched the previous video on periods and hormones, then we recommend checking that out, as it explains what happens throughout your natural cycle, which will give you an understanding of how the following medications and hormones might be useful. Most people will have tried anti-inflammatories for their pain. Common brands include Nurofen, Naprogesic, Ponstan, and Celebrex. These medications act on prostaglandins, which are the inflammatory chemicals released with ovulation and periods that can be associated with pain and bloating, and really work best when you start them early, so even the day before your period, if you can tell when it's coming, and if you take them regularly as well. Doing this helps keep on top of inflammatory pain before it gets away from you, and also will reduce the amount of blood loss if taken regularly. Although there are some risks with prolonged or high-dose anti-inflammatory use, taking for a few days at a time is generally considered safe for most young people. Just because one type of anti-inflammatory doesn't work doesn't mean that another won't, so it can be helpful to play around with different types, even including rectal suppositories, which some people find more effective and long-lasting if you feel comfortable with using those. And just to note that if you find Ponstan is effective for you, keep in mind you can get a script from your GP for cheaper supply. A quick note on cyclocapron, which is not a pain medication itself, but a medication that is used to reduce bleeding, so can help inflammation and pain as a result of that. It's commonly used, particularly where people are wanting to avoid hormones but have heavy painful periods. It can be titrated to effect, so you can change the amount of tablets and frequency depending on how heavy your bleeds are, but it can end up adding up in terms of the number of pills you're needing to take, and it's also not on the PBS, but can be used alongside your anti-inflammatories to reduce bleeding. In terms of supplements and over-the-counter medications, there are many, many out there. Where possible, it's always best to get nutrients directly from a varied diet. And it's also really hard to get good quality evidence on supplements and herbal medicines. But certainly, if you have any identified deficiencies like iron or vitamin D deficiency, then those should be replaced and you should get specific advice about the doses required for that. Recommendations on other supplements might be based on other symptoms you have, like insomnia or constipation. So it's worth working through your specific symptoms with a nutritionist, dietitian, or GP. There are some small studies showing possible benefit from things like zinc in period pain, melatonin, largely through its impact on sleep, and other supplements like PEA and NAC. Essentially, we recommend discussing any supplements you're taking with your team, though, because even if supplements are considered natural, they can still cause harm in excessive amounts or if taken for prolonged periods of time, and the costs can add up as well. So, as with any prescribed medication, we recommend trialing for a couple of months and then review whether you think it's actually helpful for you. And if you do intend to take it longer term, discuss with your team. This resource at the bottom of the page is a good resource that you can also use to look up the safety profile of herbal remedies and check out whether any supporting data does exist. So coming now onto hormones, a lot of people feel like they go to their GP with pelvic pain and are given a script for the pill and sent on their way. And understandably, that can feel really dismissive. But given our cycles and periods and conditions like endometriosis are driven by our hormones, at this stage, the main medication options that we have to modify or stop those processes are also hormones. This lists all the different categories of hormonal options available in Australia at the moment that can help reduce or stop bleeding. And they all work in slightly different ways and have different side effects profiles, including some positive side effects for some people. So understanding your options and feeling in control of your choice can be really helpful. At this stage, there's no good studies showing clear superiority of one type of hormone over the others for endometriosis or pelvic pain. So ultimately, the choice should be based on your medical history, your preferences and priorities, and how well you tolerate different hormones. So we do want to acknowledge that in many cases, it really is a case of trialing different options, ideally for more than 3 months if you can, to get a good idea of how it goes for you. And then seeing what works best and if the benefits of that hormonal medication outweigh any side effects. It should also be noted that these don't have to be medications that you stick with forever. You might chop and change throughout your reproductive life or have breaks. But even just trialing some of these and taking away your period, even if it's just for 6 or 12 months, that can be a good circuit breaker for pelvic pain and allow you to engage in other therapies. So many people with pelvic pain will be recommended the combined oral contraceptive pill, or the pill. Basically, combined contraceptive pills contain both estrogen and progesterone in a packet with a number of active hormonal pills and then usually 4 to 7 inactive or sugar pills in a packet. They work by the progesterone part of the tablet, essentially tricking the brain into not releasing stimulating hormones so that you don't release an egg from the ovary. And so it takes away the natural estrogen and progesterone surges throughout the month. And so you take that hormone tablet daily to give a steadier level of estrogen and progesterone throughout the month. And then when you take the sugar pills at the end of the packet, you get a drop in the hormones that leads to what we call a withdrawal bleed. The steady level of estrogen and progesterone throughout the month means that there's less stimulation of the endometrial lining. And so there's less thickening. So when it comes time to have that bleed, there's less blood loss, less inflammation, and hopefully less pain as well. That steady level of hormones throughout the month may also help reduce premenstrual symptoms. So if you suffer with migraines or sore breasts, mood changes in the week leading into your period, or altered pain sensitivity around that time, the contraceptive pill may help with that if we can find the one that suits you. If you take the sugar pills at the end of the packet, obviously you may still get some bleeding and some premenstrual symptoms, but hopefully to a lesser degree. But for most people, what we recommend to try and avoid this altogether is that you try to skip your periods or take the pill continuously. So just quickly, what we mean by skipping your period, it's not really skipping a period per se, because while you're on the contraceptive pill, we're taking away your natural cycle, and the bleeding that you get is actually a withdrawal bleed. To skip that withdrawal bleed, when you get to the end of your active hormone tablets in a sheet of the pill, you then skip the sugar pills and move straight on to the hormonal pills in the next packet. So you get a continuous level of hormones. It's very safe to do this and to not bleed each month. Some people worry that the endometrial lining is continuing to build up inside them, but this is not the case. We can very safely go long periods of time without having periods or bleeds. That being said, skipping withdrawal bleeds can sometimes result in some breakthrough bleeding, and you may occasionally need to have a short break. And so for more information about how to do this, search the Royal Children's Hospital website, Skipping Periods on the Pill, which has a good summary of how to troubleshoot. Just to address a few of the common concerns that come up with contraceptive pills. A lot of people will stop a contraceptive pill in the first 3 months because they're getting irregular bleeding. Unfortunately, this is common with almost any hormone that we try in the first couple of months, and most will settle with time. So if you can stick it out for 3 months, it will often get better. If not, then you can review and change the type. In terms of fertility, there's no long-term impact on fertility with the combined contraceptive pill, but for some people it can take a few months after stopping for their periods to become regular again. So that's just worth keeping in mind if you have any family planning considerations. From a cancer perspective, there's actually a reduced risk of ovarian and uterine cancer for users of the contraceptive pill, and that effect actually lasts beyond stopping. While you're taking a contraceptive pill, there is a slight increased risk of breast cancer, but because generally for most people at the age of taking a contraceptive pill in your 20s, 30s or 40s, your baseline risk is likely low. Even though that risk is increased, it's still very low overall, and that risk will reduce after stopping the contraceptive pill. Weight gain is another huge concern for a lot of people. And yes, progesterone can increase appetite and estrogens can cause some fluid retention. It's difficult to get really good studies, but large-scale reviews of available evidence show no significant or large-scale effect on weight. Some studies show women will gain weight while others show that they lose weight, but the majority will generally start within 2 kilograms of their starting weight. What we tend to recommend to people is that if this is important to you, you may take your weight at the outset and again 3 months later. And if nothing else has changed in your life in terms of diet, stress, exercise, and you have gained weight that is significant to you, then that's worth reviewing with your GP. But ultimately, it will be a personal decision where balancing this with any potential benefits. But weight gain is certainly not guaranteed or expected with contraceptive use. And just one last note that commonly people will say they've tried the pill, but this is just to show that we have over 20 different options and different combinations of combined pills with varying types of estrogen and progesterone and different strengths. So don't necessarily give up on all pills because of a previous adverse reaction. We can certainly consider what you were on previously and choose different hormone strengths or types to better suit you. There's no strong evidence that any particular pill is better than another for skin or mood or pain, but there are properties of different estrogens and progestins that might help us guide our choice. For example, if you have PCOS, we might use a different pill. Not all pills are on the PBS, so just keeping that in mind as well. I'll just note that this table is slightly out of date and that Yaz and Yasmin are now on the PBS as of 2025. Moving on to progesterone-only pills. Again, these all act on the hormones coming from our brain to then alter the function of our ovaries and the lining of our endometrium, the lining of our uterus, the endometrium. They will all suppress our egg release to varying degrees, but certainly some of the newer progestins available are much better and better tolerated. In terms of the progestins that are licensed for contraception, the first two in this table are our older mini pills, which are slightly less effective and a bit more stringent in terms of timing. But drospirenone or Slinda, which is one of the newer progesterone-only pills, has just recently come onto the PBS, which is fantastic news because it's much more effective as a contraceptive and seems to be much better tolerated and particularly more useful for people that have significant premenstrual symptoms. These are a couple of the non-contraceptive progestin options. They might be used by themselves or sometimes in addition to other contraceptives like with an IUD. And again, just to note that Vazan has just recently come onto the PBS and is licensed specifically for endometriosis. So that's now a much more affordable option as well. Some of the longer-acting progestins that we might use include the Implanon, which is the rod device that's inserted into the upper arm and lasts for 3 years. The depot injection, which is a 3-monthly injection. But really the long-acting progestin that we use the most is generally the Mirena, an intrauterine device that has just recently been licensed for up to 8 years. These hormonal intrauterine devices sit within the uterine cavity. They're a set and forget option. They release progestin hormone locally in the uterus, so you'll end up with less hormone dose in the bloodstream than contraceptive pills or Implanon or Depot. Although they can stop you from ovulating in the first few months of use, generally after that doesn't reliably stop ovulation. So you may still feel cyclical symptoms in the background and get premenstrual symptoms, but when it comes time to having the period itself, the effect of that progestin is reduced bleeding. It is lower dose, but still all the same potential hormonal side effects are listed, but often short-lived if they do occur. You can also combine this option with tablets or other hormones if it's not controlling all of your symptoms. The two options we have in Australia at the moment are Mirena and Kylena. They're the same hormone, but just in differing doses. Generally in pelvic pain, where our preference is to use the Mirena because it's more likely to stop bleeding. So it reduces bleeding by about 85%. and there's a good chance that you'll stop having periods altogether. Obviously, there are some costs to consider, but given that it's now licensed for 8 years, over that course, it ends up being quite a cost-effective option. Some people will find that if they've got heavy periods, they might need to change it over sooner. Finally, these are some of the more specialist medications that may be trialled if you're not getting good effect from previous hormonal options. These include Zoladex implants or Cineral nose spray. These are generally prescribed by gynecologists and are used to suppress your ovaries more strongly than the previous options. And so essentially they're temporarily putting you into a prepubertal or a menopausal state. And so generally you're on these medications for up to 6 months, and depending on side effects and how you're feeling, you may need to add back some low-dose hormone therapy on top. These ones are on the PBS if you do have laparoscopically proven endometriosis. Ryequo is a tablet option that has recently come onto the PBS, so is now much cheaper. They can be prescribed by your GP, but there are some monitoring requirements and side effects to look out for, so it's worth individualised discussions. Just quickly before we finish, I wanted to mention a few more medication options that we use for persistent pain or pain system hypersensitivity. So our central nervous system, which contains our brain and spine and all the peripheral nerves that go out to every part of the body, is obviously hugely involved in our experience of pain. The nerves in your pelvis that supply all of the tissues and organs send messages to the spinal cord and up to your brain, and vice versa, the brain sends messages down to the pelvis as well. While the previous medications all deal with triggers within the pelvis, the following medications act on the brain and nervous system signaling to dampen down the pain system and pain response. This is particularly helpful for people with symptoms suggestive of what you may have seen referred to as central sensitization or pain system hypersensitivity. While this terminology can make it sound like you're overly sensitive, what it actually means is that your nerves and brain are more responsive, and over time, pain has become the default experience, and things that maybe didn't cause pain in the past now do. So if you notice that pain now occurs outside your period or your initial triggers, maybe on more days of the month and spreading to other areas of the body without clear triggers, or if you experience associated symptoms like fatigue, brain fog, dizziness, and mood changes, then this is likely to reflect an issue with your nervous system functioning. This might be particularly important as well to consider if you've been diagnosed with other chronic pain conditions. We see a lot of overlap with conditions like fibromyalgia, chronic fatigue, migraines, and vulvodynia, which all have similar nervous system drivers. So we use the term neuromodulators for a variety of medications that we might trial that work on nervous system signalling. We won't go into too much detail here, but just to say that neurotransmitters are chemicals that send messages from one nerve to the next. Our aim is to dampen down this signalling. And so these medications are taken daily and often take time to have effect. So it's not a medication that gives immediate relief, but one that over time hopefully reduces the intensity and frequency of pain. And so it may require some dose adjustments and patience until you seek good effect. Generally, the first line medication that's trialled is a medication called Endep, or otherwise commonly you might be recommended another medication called Cymbalta. Second line are other medications like Lyrica or gabapentin. All of these medications have a number of side effects. So but can be really effective in some cases. So I recommend checking out the Pelvic Pain Foundation of Australia website for more information on each of these medications, just via the web page there. It's also worth considering that if you're thinking about these drugs and modulating your nervous system, think again as well about all of the non-medication options that exist to help calm and retrain your nervous system. If you're a part of our pelvic pain clinic, I really recommend you attend our other group education sessions to consider some of the other therapies and activities and supports that can help your nervous system. And just finally, a note on opioids and why we try to avoid them as much as possible in persistent pain. Synthetic opioids, which are drugs like codeine, oxycodone or endone, tapentadol, this is a family of drugs that certainly can help with pain in the short term, so might be appropriate for the first few days after a surgery or an injury, but they have lots of side effects and that can often make pelvic pain worse, particularly constipation. There's no evidence that they have benefit in persistent pain, and long term there's very high risk of dependence or tolerance and addiction and needing to take higher and higher doses. And it's actually been found that they further sensitize the nervous system, so make that pain system hypersensitivity worse. And these are drugs that with increasing doses can really risk problems with breathing and overdose and even death. So ultimately, we want to acknowledge that there's no perfect medication that will treat all symptoms and that has no side effects. So it's worth considering the information that we've talked about in this presentation and be open essentially to a degree of trial and error to figure out what works for you. But here are some things you might want to talk about with your GP or anyone prescribing you medications. So asking them what the medication is trying to target and how it works. It can be helpful for you to tell your doctor about your previous experiences with medications and hormones so that they can tailor future choices with this in mind, or arrange investigations where appropriate. As always, asking about the costs and whether medication is available on the PBS or a similar alternative. Asking about side effects, considering what your fertility plans are and whether you need contraception at this time and whether the medications prescribed provide that. Considering as well what the additional benefits of each might be. For example, will they help with migraines? Will it improve skin, reduce mood fluctuations, help with sleep? And considering as well, what's the alternative look like without that medication or without that hormone? What other non-medication alternatives can you utilise? Hopefully this presentation has given you a bit more of an idea of some of the main medications commonly used and helped you to feel empowered to discuss with your healthcare team and be supported to make the decisions that are right for you.